lens focus. Next, we have the premium IOLs in today's practice by Dr. Krishna Prasad Kutlu. So,
Thank you so much, Kerala Ophthalmological Society, for this opportunity. So, I'll be talking about premium IOLs, and I don't have any financial disclosure for this particular talk. So, what is premium? Generally, we consider multifocals, trifocals, EDOF are considered to be a premium. Toric multifocals also part of premium. Toric monofocals also part of premium. Even nowadays, even most of us consider aspheric monofocal lenses also considered to be premium lenses. Coming to the patient selection, for me there is no age criteria. Youngest to the oldest, he can opt for premium. But always I avoid multifocal in patients with the congenital cataract. If I do a cataract in one eye in especially young patient, I avoid multifocals. Coming to the occupation, premium monofocals and torics are for every profession. I always avoid multifocals, especially in drivers and profession with fine arts, pilots, surgeons, even armed forces. Again, depending upon the surgeon choice. But these multifocal or trifocal best tolerated by retirees, housewives, computer professionals, writers. As Dr. Anish said that EDOF is the best for drivers and software persons. So always you should look at the patient attitude. Always patient is think that I don't mind wearing glass for reading. I always avoid them. Some of the patient ask me, will you guarantee spectacle independence? I always tread carefully. Some of the patient like complained of glare, I think you have to counsel them well. Then the worst scenario, what I always feel that I paid all this money and I have to wear glasses, they may ask. So coming to the clinical judgment, it's very important to ask for a amblyopia history. You need to look for pinhole vision, color vision, and comorbidity like age-related macular degeneration, glaucoma. This is very, very important. So often where we missed, always all my premium patient, I do the proper dry eye workup. You treat the dry eye, then you go ahead with the treatment. Always I do corneal topography just to rule out any irregular cornea. I do OCT to rule out any epiretinal membrane or age-related macular degeneration. I got a scan where I can find out whether the patient is having a loose zonules, and always make sure that patient doesn't have glaucoma. So coming to the post-keratorefractive surgery, will you implant a multifocal? Again, depending upon their regular ocular surface. Then what is the near ad for multifocal? Can we advise trifocal to all the patient instead of multifocals? Leaving aside the financial consideration. Then next question arises, need to operate both the eyes in quick succession or not? This is very important. So coming to the preoperative counseling, is as Dr. Chandrakant said, is very, very important. Always you have to tell the patient, sometimes they may require to wear the glass for a very fine print, and every patient I tell them that you have to read in extra light condition. And always you should show them the advantage of spectacle free vision, and also you should tell them, always you should look at the other eye condition. Always you better to avoid a hypercritical and demanding patients, and keep always option of monofocal open in technical difficulties during the surgery. This is very important. And also tell the disadvantage of intraocular lens also. So coming to the point about biometry is very valuable too. Although premium IOLs can be practiced with ultrasound biometry, but sometimes every surgeon will have a fear of surprises. Because sometimes what happens, these newer formulas may variable with the difficult to obtain from a scan. Always I opt for this kind of biometry. Because the advantage with this biometry, you can have a full length tomography that shows the anatomical details in the longitudinal section of the eye. We can have an accurate AC depth, and even it can even find out about the suspected any tilt of the crystalline lens. Coming to the post-keratorefractive surgery, probably I don't have any financial interest with the IOL Master 700. Probably TK is probably priceless future. You will have this Barrett True K formula that gives the perfect reading. That is very, very important. So coming to when you're practicing with these premium IOLs, with this visual angles is important. I personally feel yes, because angle kappa is a angle between the visual axis and the pupillar axis. The most important one in cataract surgery is angle alpha, which is the angle between the optical axis and the visual axis. So angle kappa is more important in refractive surgery, especially when you are dealing with a hyperopic patient. But Of course, larger angle cuppers sometimes, if you do it even in a patient with hypermetropic, sometimes may have a decentration in the IOL. So coming to the angle alpha, as I said, that most important in cataract surgery, uh, because it can be like, see, if it is more than 0.6, then better to avoid multifocal lens. This is very, very important. So I always do aberrometry workup all these patients when I do a premium surgery. At 4 people, more than 0.3 micron of higher order aberration, which cause a blur similar to the 0.5 diopters of defocus. So I normally won't implant trifocal, especially higher order aberration more than 0.7, coma is greater than 0.5, all these detail, because I do have got eye trace, no financial interest. So this is the advantage. If you're having eye trace, you can get the much all results, especially regarding the MTF also. So after talking all this, sometimes our first choice is going to be the monofocal intraocular lens. Probably we have to tell the patient that they have to wear the glass for near and intermediate distance. So because this avoids annoying the halos and glare and halos. Of course, multifocal intraocular lens have got a diffractive step on the IOL implant that create a smooth transition between the focal point. Of course, for housewife it does well. But which was not addressed is the intermediate vision with this multifocal. Especially it was problem for some of the occupation like drivers, computer professional, painters. They have to really change their lifestyle modification. So there comes, I think, the trifocals. Most of us been converted into trifocal. This was my earlier video. I've been used more than, I think, 1,500 lens of trifocal from Zeiss, and which gives me very good result. That is Lisa 839 model. It comes even in the toric platform 939 model. Always I believe that the 4-haptic platform, the stability of the lens as far as toric is concerned, I am for that. Once again, depending upon the surgeon's comfortability. So these are the advantage with the multifocal lens. Patient will have a distance, unaided, intermediate and near vision. Freedom from the glasses, of course, good for indoor activity. But there are disadvantage. It compromises the quality and contrast sensitivity, and also glare at time unbearable in night driving. Some need to wear the glass for very fine print. They require extra light, especially not suitable sometimes for a skilled work. And sometimes you may have an unsatisfied patient. So for all these patients, short-term glare and halos also will be intolerable with those who are doing the active night driving. There comes again monofocal and EDOF. So coming to the what is true EDOF, what just in continuing with Anish discussion, what is this true EDOF? I am talking first about the true EDOF with the rings. So these lenses are actually excellent compromise of benefits of both monofocal and multifocal lens. More spectacle independence compared to the monofocal lens, with a fewer visual side effect compared to the multifocal IOL. They may be little bit okay with the sensitivity with the visual side effect, but except to wear the glass for a near print. So coming to the what are these monofocal EDOFs? These are the newer monofocal IOL, does not have the rings. So I am talking about this lens because of the time I am trying to rush in. These don't have the rings, especially this newer one. This is the lens from Rayner EMV lens. I don't have any financial interest. It has got anterior aspheric anterior surface. It has got a controlled positive spherical aberration in the center of the lens, and also if the edge is such a way that it reduces the longitudinal spherical aberration. Very important, doesn't have any ring, so that reduces the dysphotopsia. This is one of the, I think, first few lenses I operated quite first time. The results are amazing. What I do, I make the dominant eye emmetropic, make the non-dominant eye myopic by 0.5 to 0.75. That gives me the very good results. So I will not be showing. So in the end, I want to talk about why torics are good. Because torics are much superior than any of the LRIs. So in my practice, more than 0.75 diopters, I always go for toric lenses. Where you will have problem, because sometimes with the preoperative measurement, sometimes you may have a surgical induced astigmatism, incorrect placement of the IOL. Sometimes patient may have a cycle rotation also. What happens, 1 degree of in torics malrotation negates 3.3% of toricity, and 0.65 to 3% cases more than 10 degree rotation may have a axis needed for re-rotation. So this is very important. There are different, I do have got a Callisto system with me that give a fantastic result. I don't have any financial disclosure, but those are starting toric practice also. There are a lot of bubble markers are available, but I do with this something like one of my friend Saurav Patwardhan toric marker. This is a smartphone gyroscope that gives a equal, we did a study that gives a equal results how all other, even toric app is giving with very good results with this. So improving the toric outcome, always counsel the patient appropriately. Plate haptic lenses, according to me, offer better capsule stability than less rotation than postoperatively. Best is, of course, markerless system, because it can take the data from the IOL Master 700. So always intraoperative exclusion criteria for premium IOL is very important. You need to, if you are having, then you should not put, if you are having a vitreous loss during the surgery, zonular damage, capsular exis, capsular rupture, and pupillar trauma during surgery. In conclusion, optimization for toric IOL is very important. Good self-sealing incision, keeping in mind surgical induced astigmatism. 5 mm central round rexis is the key. Complete visco removal and wound hydration is very, very important. Recheck the alignment before removing the speculum. Premium IOLs give a higher spectacle independence and patient satisfaction, give us a recipe of success. Again, I thank all the members of KS and all my seniors for this opportunity. Thank you one and all.
Thank you, sir. Thank you. That presentation was really nice. And